Welcome everybody, another sunny day in beautiful paradise here. I'm here once again with Gary Green, our infectious disease doctor. Of course, we're practicing safe distancing today. Unable to do masking because you just won't be able to hear us very well. So today we're going to talk about COVID testing, but before we get to that, I have some questions for Gary. Gary, we're seeing on the news day after day increasing number of COVID infected patients across the nation. But I know there's more testing going on, so how do you follow this phenomenon? What are you looking at?
Thank you very much. It's nice to be here today. So the rate of positivity of nasopharyngeal swab testing is very important. So just a few days ago, the Public Health Department had the highest number of daily cases in any single day, 50 positive cases. But the real question is, what percentage of our testing is positive? So right now at the Public Health Lab, 2.1% of the swabs are positive. A few weeks ago, that was 4%. So our testing rate of positivity is going down. That's how we know we're flattening the curve. Now, what you want to know is asymptomatic versus symptomatic testing. Overall testing, 2.1%. And if you look at our respiratory clinic, overall testing, 0.8% of those tests are positive. So for the population we're serving, our testing rate is even lower. For asymptomatic testing, we don't have that data from public health, but our respiratory care clinic is 0. Of all the asymptomatic patients that have come in for testing, 0 have tested positive at our respiratory clinic, and that's very reassuring. So there is virus in the community. How do you put that in context? Because they're numbers. What about the flu season? When the flu season starts, we, from a laboratory perspective, say it starts when 10% of our swabs are positive. So when 10% of our flu swabs are positive, we call that the flu season. During the peak of the flu season, up to 40 to 50% of our swabs can be positive. The other way to look at that is, what about other states? New York, for example, at some point, their testing rate was 30% or higher. So at some points in the epicenter of New York City, 30% of their swabs are coming back positive, and that overwhelmed their medical system. So that's the best way to keep those numbers in perspective.
Wow, okay. That's actually very reassuring in that what you're stating is that the population of patients we serve, the infectious rate is very, very low. So, another question, we've talked about this a little bit. Help me understand the difference between an asymptomatic patient and a pre-symptomatic patient.
Yeah, there are two different categories. The pre-symptomatic patient is the patient who's incubating the virus, but in a day or 2 or 3 or 5, they're going to develop symptoms. They're in the incubation period. So we call that pre-symptomatic. The asymptomatic patient is a patient who is infected. You can detect the virus in a nasal swab, but they never develop symptoms, even beyond the incubation period of 14 days of the virus. So the real question is, the CDC uses 14-day incubation period as 99% of how long the virus will incubate in any individual. What's the average? The average healthy person will incubate the virus and become symptomatic in 5.6 days. So that 5 to 6 days is a very important marker for when we start testing people in the asymptomatic arena who otherwise need to be tested.
Gary, we talk about testing of patients. We're getting calls from asymptomatic patients, but if we can't test them, I believe the CDC would have other recommendations. Quarantine?
So the CDC has clear recommendations on asymptomatic testing based on priority risk. Now, in a perfect world, you'd want to test everyone, but we just don't have that testing capability. No one really does nationwide. If we tested everyone, asymptomatic or symptomatic, then it would take a long time to get our tests back, or just run out of reagent. So the CDC has 4 tiers, or 4 priority groups. And priority 1 is the people who we prioritize in testing. For example, people undergo anesthesia, for example. We'd want to know that beforehand so they didn't have a post-operative complication because they were incubating the virus. So we're limiting our testing to priority 1 patients, not priority 2, 3, and 4 yet, so that we are able to manage our resource in a period of time when our asymptomatic testing rates are so low.
So it sounds like if a person isn't able to get a test and they're asymptomatic, simply quarantine yourself for 14 days is adequate.
Yeah, the 14-day quarantine is following CDC guidelines. For people who cannot get tested, then we recommend they self-quarantine at home for 14 days.
Okay. Well, as the numbers are going up and as our community is opening up, I think we're seeing, I'm seeing more and more people call my office with requests for testing. Either they're visiting a grandchild, they need a test to go back to work, they had a friend who was exposed to a friend. And I think you're all getting those tests. Problem is we can't handle all those. Let me talk to you the reality of our capacity here at Sutter. So We send all of our labs to the Sutter Shared Lab. Sutter Shared Lab has the ability to perform 2,000 tests a day, but this is for all the Bay Area medical groups. Currently, they're running about 1,800 tests a day, and they give us tremendous service with a less than 24-hour turnaround. Once we exceed that 2,000 a day, they need to start sending those labs out to other resources such as Quest. Now your turnaround time is turning into 3, 4, 5 days. 3 or 4 or 5 day turnaround is really not adequate for us in terms of making clinical decisions, or certainly not adequate if you're trying to time a negative COVID test in advance of a scheduled surgery. So let's talk about the reality of what we're doing here at Sutter Health, because we cannot test all of our asymptomatic patients. We have our respiratory clinic, and my first slide shows what we're doing at the respiratory clinic. So you know that for all of our symptomatic patients, they're not allowed to enter in our office. They're all referred to the respiratory clinic. Your MA, your PSR, your nurse triage, they all have the ability to schedule patients into the respiratory clinic. Their hours are from 7 a.m. to 2 p.m. Every patient who's sent to the respiratory clinic with symptoms will be evaluated by a provider. And they used to do this in tents. Now we're getting ready for the winter. We're starting to bring them inside. And the staff at the respiratory clinic will take responsibility for notifying those patients of their results. So I think you've probably all had some experience with that. So we've created new systems for our asymptomatic patients. So these patients are there for testing only. They're not there for an evaluation by a provider. Their hours are 8 a.m. to 4 p.m. This is done outdoors, tested by an LVN and perhaps an MA as things evolve. We have very distinct categories of people we're testing. We're currently testing our ASC patients, so these are patients who are pre-op for our ambulatory surgery, and in fact all the patients having surgeries in the hospital, and in fact all admissions to the hospital now are being tested for COVID by the hospital, not by our clinic. We are also testing the OB patients who are being admitted for elective things such as a C-section or an induction. We're testing people who are about to undergo high-risk procedures. You might think of an endoscopy, for instance. And we're testing people who have acute on chronic conditions. So the best example of this might be a patient with chronic COPD who's developed a new cough. You know, traditionally we think of this as a flare-up of their COPD, but before we see them in our office, we want to make sure that they're asymptomatic from a COVID standpoint. These patients will be tested in this clinic, and then with a negative test can be seen into our clinics. And then the last one is newborns and positive mothers. Should be rare, but an important test that we can perform in our clinic. So we are following Sutter guidelines and how we do our testing. As Gary mentioned, there's several different tiers, but at this point we're only capable of doing these guidelines. So to help you communicate with your patients, we've made a smart phrase that is available to you. That goes by the name of Smugger COVID Asymptomatic Testing. It's on the screen. You can read it now. All of you can use this when you're responding to patients with an MHO. It does reference a website where they can go, briefly set up an account, and then it allows them to directly schedule a COVID test at different sites. There's one in Santa Rosa and at least one, if not more, in Petaluma. So you can communicate that with them. Instead of just saying we can't do it, you have some resources to tell them. And of course, if it's not a timely thing like we mentioned before, it's perfectly acceptable for these patients just to self-quarantine for 14 days. Well, thank you for watching today. I think it's important that we all understand why we're testing and what the limitations are in our testing, so that all of our providers and our staff are on the same page and we can give a uniform response to our patients. I hope you continue to watch these updates. I hope you find them useful. As you've discovered things change, we might be coming back with different guidelines for our clinic any day. So Gary, thanks for coming today.
Thanks very much. Nice to be here today.